Maria's going to be talking about multi-morbidity and community resource, a call for reconceptualisation.
I'm talking about the qualitative counterpart to Mark's study. So we were funded to also look at some of the qualitative themes underpinning multi-morbidity locally in Lambeth and Southwark by the Guy's and St Thomas charity. And I shall be talking about the findings of that study. So the aims of this were to facilitate a greater understanding of multi-morbidity, but also to think about the role that community assets may play in terms of interventions, or as an alternative perhaps to what's on offer in the already quite strange statutory sector. We wanted to look at community attitudes towards interventions and community resources for multi-morbidity. So Mark already has set the scene regarding Lambeth. So Lambeth is the 5th most densely populated borough in England and Wales. Southwark, I believe, the 9th. Both very diverse, so around 150 languages spoken. Between 40 to 50% of Lambeth and Southwark citizens describe themselves as English white. There are pockets of deprivation, and around 60% of those with a limiting health condition are aged 50 or over, which does suggest that 40% are not, and therefore we started thinking about really maybe we need to look at long-term conditions in a different way, especially multi-morbidity. So in some way this study was going to be a call for reconceptualising the way we look at multi-morbidity locally. The charity have a long-term conditions programme. They're aiming to put £250 million over the next decade into this. And the aims of the programme are to understand more about the progression to multi-morbidity, how people transition, so a kind of life course perspective, but also thinking about the community assets on which to build activity. So the word assets is used within the charity's documentation, suggesting that this is really something that is rich, that can be built upon for better interventions for multiple long-term conditions. So what methods did I use? This was a scoping study. We were given around 6 months. So for those of you out there who are anthropologists, you may wince at this a bit, but I used a method called rapid ethnography, which isn't your traditional embedding yourself in the field for 2-3 years. We had 6 months, which also included things like ethical approval, recruitment, etc. But rapid ethnography is increasingly used by policymakers as it brings together multiple sources of data to build a case. So to really deliver findings when there's a limited time frame. So I brought together multiple data sources and looked for overarching themes using an iterative analytic framework, which meant that the themes evolved as the study went on. I carried out 5 mini-studies during this time. One of them included a review of the literature, then looking at local policy and guidance documents for Lambeth and Southwark, a thematic analysis of community stories. So unfortunately, the time frames meant that we weren't able to recruit patients directly to the study, but I looked at stories from patient representatives in the community that were publicly available online and synthesised those for themes. The wider charity work does include the patient voice very much so in the final report that was produced, which included some of Mark's work and mine also. So the patient voice is really regarded as something quite important when it comes to the charity programme. I carried out some targeted semi-structured interviews, just 5 of key community representatives, and also looked at what's available in the community for multi-morbidity. So to bring this all together, just to summarise using 3 overarching themes. Theme 1, multi-morbidity is multifactorial and complex. A single disease focus was largely viewed as unhelpful. And a single disease focus is something that leads to a perceived lack of joined up services for multi-morbidity. So really, the policy at its core perceived success in treating multi-morbidity as delivering a fully integrated system of care. However, the reality on the ground was quite different, that actually there are stresses around chasing multiple appointments in various settings. We have all these different people visiting all the time from different medical disciplines. It's so frustrating. We have to explain everything over and over again. So there is a clash between the policy rhetoric locally and what appears to be delivered on the ground. The second theme was around holism. So, and we know this, don't we? I mean, this keeps coming up, that actually a biopsychosocial framework, a biopsychosocial lens through which to understand multi-morbidity is key, but also should be a consideration in the way we design treatment. So the first quote is quite revealing. I needed help from someone who could look at me as a whole person. Allowing time to hear people's stories is so important, to learn about context rather than jumping to solve problems in a purely biomedical model. I created a word cloud of some of the key themes that were coming up in the community stories, and as you can see, they very much link to feelings, perhaps a feeling of helplessness, inability to cope. And you can't see this very well, but I saw this on Twitter. It's not directly related to the study, but on the left here is the vocabulary of the medical world when it comes to long-term conditions. So diabetes, arthritis, COPD, and here we've got the user voice, frustration, identity, fear, loss. So again, moving away from a purely biomedical approach to multi-morbidity feels appropriate, and certainly the findings of my study supported this. And the last overarching theme was to do with community assets. It was really felt that community assets locally have an important role to play, and they could very much deliver that holism that there seemed to be calls for within the interviews. So looking beyond the medical model and also taking away stigma from having multiple long-term conditions. It was also seen as a way of solving the funding difficulties. I know it's apparently the end of austerity, but we haven't felt it yet. So perhaps community is a way of taking things forward, says this particular participant. And we need to build on existing assets to address localized social determinants of health. So really, this supports calls for a joined-up approach and integration. But I argued that we need to reconceptualize the way we look at multi-morbidity before there's a meaningful integration when it comes to service delivery. Then I tried to frame this in the context of pre-existing literature, so looking at multi-morbidity from a life course perspective, something that Malaise and others termed multiple dimensionality. Moving away from a single disease focus to how the various diseases come together, how they interact, and how people form their identities. And also continuity of care and better organisation was seemed as something that was really quite pressing to the participants in my study. So I drew some conclusions. It's a shame that the syndemics talk was cancelled because you would have had a bit more of a backdrop to syndemics. If you do want to read more, there was a whole edition about syndemics in the Lancet in March 2017. But syndemics are all about how disease interacts with the social, environmental or economic context and looking at the factors which may promote this particular interaction and how they may worsen disease as a result. Syndemics are viewed as a reconceptualisation again, and one that could play a significant role in tackling health inequalities. So if you are interested, I'd urge you to read more, but certainly findings of this scoping study suggest that contextual factors are key in the way we conceptualise multi-morbidity and how we design interventions. And lastly, because my findings pointed quite significantly towards the role of community assets, I then asked the resulting question, which is how do we actually design these? How do we implement those types of interventions? How do we strengthen them to deal with the ever-growing demand? So again, I looked at pre-existing literature and guidance on these subjects and thinking about futures, perhaps the next steps for the charity programme is how we involve family, community in their design, how we make them flexible, how we implement cross-system collaboration is an important thing to consider. They need to be integrated and culturally relevant. I haven't had time to talk about it today, but certainly when I appraised the community assets available in Lambeth and Southwark, they served very specific populations, they were tailored, they appeared to be quite culturally relevant, which is something that at times the statutory sector can struggle with. And also thinking about the demand for holistic multi-morbidity provision. What does that mean in practice? That people's attitudes, psychosocial factors are going to affect how successful community assets are perceived to be. And we also, of course, need to think about issues of limited financial resource, sustainability, and how we actually market provision, particularly with hard-to-reach groups. And lastly, this is the charity report, which cited our work. So if you are interested, you can Google that, From One to Many. And as I say, there were lots of patient, client, user stories within that report as well, which enhance some of the work that we've talked about today further. Thank you very much.
Thank you very much for that. Any questions or quick points of clarification before the larger discussion? No, in that case, I'd like to hand you over to my colleague, Alex Dragan, who is going to lead the discussion about the presentations we've just seen. Thank you.